Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Liza Ali from online learning educational tawakkul group. Today we are going to do for this written Rcpi recalls of March 2026. Actually, this group we are having this RCPI both for the written and the OSCEs. But for the MRCOG, we just newly started that MRCOG group only for the written part. So this is the one which we are going to do this MRCP March 2026 part 2 written SBS. Okay. So the first one is that first question is that a patient. I have to first share with you this news that this has been shared with us with a kind-hearted person, not disclosing the name. But I am very thankful from my side and from my group for providing us this recalls. Okay. So the recall number one is that the patient should develop difficulty in extending the knee and has an anterior medial thigh and medial leg sensory deficient filing gynecological surgery. The question is that which nerve is most likely injured. So the options are the femoral nerve, sciatic nerve, common peroneal nerve, and the obturator nerve, and the last E is the lateral femoral cutaneous nerve. Here the thing is that it will be the femoral nerve. The answer is the femoral nerve. So here see what the explanation is that the patient's symptoms which they describe in the question is that she has a difficulty in extending the knee. Means extending the knee means the muscle which are mostly affecting the quadricep weakness, which we call it quadricep weakness, and sensory deficit in the anterior medial thigh and the medial leg sophonous nerve distribution. So, filing any gynecological surgery are characteristic of the femoral nerve injury. This nerve is often injured during the pelvic surgery due to the excessive compression from self-retaining retractors such as a Belfour or the Buckwalter on the psoas muscles, or stretch from the prolonged hyperflexation of the hip in the lithotomy position. So we have to understand this paragraph to be remembered, that because this is a very frequent MCQ question. So please don't forget this question. This will be the femoral nerve. Sometimes they can change this thing, anterior medial thigh and middle leg sensory deficient. So I will try to explain you with the pictures when we are going to do the next continuation of our recalls. Okay, so here just they are telling about the problem is anterior medial thigh and the medial leg sensory deficit which is affecting. So it will be the femoral nerve. Two reasons: due to the prolonged compression with this retractor, or it has been long prolonged stretching. Okay, that means stretching hyperflexation of the hip. So these are the two. Now the second question is that a 24 years old woman presents with progressive hirsutism, deepening of the voice, acne, and and secondary amenorrhea. So the ultrasound shows an ovarian cystic mass. What is the most likely diagnosis? So here the question they are telling us that she is 24 years old with progressive. This is a very important uh, word, means important point, that she is having a progressive hirsutism, then the deepening of the voice, acne, and the secondary amenorrhea. So it means she is having a ovarian cystic mass. So the options will be there. She is means what will be the diagnosis. The diagnosis which they are saying, it can be a Sartori-Ligid cell tumor, granular cell tumor, functional ovarian cyst, dermoid cyst, or the Kuchenberg tumor. Now the question is here, answer is the one sertoli cell tumor. So here the question which we have to give the importance is that she is having a progressive hirsutism and deepening of the voice, acting with secondary amenorrhea, and she is only 24 years old. Okay, so it indicates, man, she is having a very severe rapid onset of androgen excess, because she start to have a amenorrhea, and amenorrhea along with the hirsutism progressively. So it means the hormone which is mostly affecting is androgen, the male hormone is affecting. So while PCO is a common cause of the hirsutism, it's typically present with chronic slow progressive symptoms and rarely causing deepening of the voice. So we have to make a differentiation with they are just to the PCOs. So here the sertoli cell tumors. So the presence, now here we have to understand there is a presence of the ovarian cyst for a mixed solid or cystic mass associated with severe virilization. Virilization means there is a high testosterone, and she is a very young lady, only 24 years old. It will strongly suggest a sertoli cell tumor. These tumors are very rare, but mostly they are unilateral. Okay, remember one thing, it is unilateral testosterone producing sex cord stromal tumor. So here the important thing here is this sertoli means these are the one who is having a testosterone producing tumors. Okay, so mostly they are producing sex cords. So what they want to say, if we will consider sertoli cell tumor, they are most common androgen. This because this in this all five options, the most important one is the sertoli, because in this all this is the most common one. Okay, this is the most common one, androgen producing tumor. If we will consider the granulosa cell tumor, so it means this will granulosa cell tumor usually produce estrogen. So what we have to do, granular cell produce estrogen, sertoli will produce the androgen, and the complaint which she is having hirsutism, progressive hirsutism, and deepening of the voice, acne, this all because of the androgen. So granular cell tumor we will not take, another the ovarian cyst, dermoid cyst, cucumber tumors, this we don't going to have considered with us. Now the question number 3, 29 years old man present with primary infertility for 18-month duration. He is a heavy smoker. Now instead of woman they are talking about the male. Okay, we have to remember that word. He is a heavy smoker and works as a truck driver. So important thing, he is a smoker, heavy smoker, and he is a truck driver and has a BMI of 35. BMI also increase. Semen analysis shows isolated statospermia, less than 4% normal morphology. His partner investigations are normal. What is the most appropriate next step? So we have to understand that person. What he is talking about? He is talking about he is a truck driver with a high BMI, because this is the partner of that lady. The lady is normal, but the partner having a problem, teratospermia, less than 4% are normal. So what we are going to do next? The stems we have to look for the stem number A, lifestyle modification, and repeat the semen analysis in 6 months. The second one, lifestyle modification, and repeat the semen analysis in 8 to 12 weeks. The C option is that proceed directly to IVF, proceed directly to ICSI. But if we will look closely of this SBA, we have to understand that he is having a BMI high 35, truck driver. Most of the time he is sitting. So two things we have to understand, two things which we have in our hand. So first we have to differentiate, proceed directly IVF. IVF we don't need right now here. This is a male, we don't need the IVF right now here, and ICSI, these two we don't need it. So the question will be there, lifestyle modification and repeat the semen analysis. Why he is talking about the lifestyle modification? Because the problem he is having, he is having a high BMI, and he is a truck driver, and he is a heavy smoker. Okay, so these are the things which he, and he is very young age, only 29 years of age. So these are the things which we have to modify. Now this we understand. Now the another question is that we have to modify and repeat this semen analysis in 6 months, or we have to repeat it 8 to 12 weeks. Okay, this is the question which we have to keep in our mind. So what he is telling is the answer is B, means lifestyle modification and repeat the semen analysis in 8 to 12 weeks. Why we choose this one? Why we did not choose 6 months? Here he is telling, if we will see his presentation, he is having a tetrazoospermia less than 4% are normal, and he is only 29 years of age with heavy smoking, and he is working as a truck driver. So means he is most of the truck driver, he is making the driving in the heat exposure. Most of the time it is will be the heat exposure and the sitting with high BMI. So the most appropriate next step it address the reversible lifestyle factors. That's the reason we have to make the lifestyle modification. These are the reversible. He can reduce the weight, he can decrease his smoking. Okay, so now the question we have to find between these two, the 6 month or the 8 to 12 week. So he is telling spermatogenesis will take place 74 to 90, means 3 months. It will take at least 3 months. Therefore, advising lifestyle modification we done, such as the smoking cessation, weight reduction, and reducing the scrotal heat exposure, and repeating the exposure. And we have to repeat the semen analysis in 12 weeks, allowing the new cycle of sperm to be produced, which are accurately reflect the impact of these changes. We have to understand that it is 12 months, means in 3 months they will take it, so it will go there here. 8 to 12 week means 2 to 3 months, because they did not tell us exactly 12 week. If they write it 12 weeks, so then we have to go for 12 weeks, but they given it at 8 to 12, so that's the reason we have to choose that one, 8 to 12 week. Okay ji. And another thing, if we will go to this one, he is having a isolated tetrazoospermia. Can sometimes we do the art, okay? Art. It is the best to the first attempt to improve the parameters naturally, particularly because the partner investigations are not. So others, if they give us what the other option you can use it besides that one, then we can use that one, the C1. But first here we have to do the modification, and then we have to use that one, and the age is only 29. So 3. Question number 4. 62 years old woman is diagnosed with stage 2B cervical cancer. Which treatment option provides the best survival outcome? A. See, the question is there, we have to understand she is 62 years old, okay, and she is having a stage 2 cervical cancer. So which is the best treatment she can have? Radical trachelectomy with an ovarian preservation, radical hysterectomy, Wardham's operation with the ovarian preservation. C is concurrent chemotherapy. D is radical trachelectomy, preserving the uterus and the ovaries, and the E1, the last one, is the radiotherapy alone. So if we will consider about all these options, so the answer will be the C. Why we will use concurrent chemo radiotherapy? Why we don't do this operation? Why will use the chemotherapy? Stage 2B. Now we have to understand here why we use this one. She is 62 years old, first thing. Then she has a stage 2B cervical cancer, which is classified as the locally advanced involving the parameter. Stage 2B is now advanced locally. It is not spread systemically. It is only the locally advanced. Involving the parametrium, the treatment that provides the best survival is the concurrent chemoradiotherapy. Chemoradiotherapy, she can has it here. Because see, here if you will consider with the first option, radical trachelectomy with ovarian preservation, she is not in the age of reproductive age. She is 62 years. She don't need the trachelectomy, okay, to preserve her cervix, and later on she can have use that one is stitching, is cervical stitch, and then she can go for the um pregnancy. Here she is 62 years, she don't need it, so the option A is gone. If we will go to the option B, radical hysterectomy with ovarian preservation, right now she don't need the radical hysterectomy because already the it is involving the parametrium, the stage 2 means. So if we will go with the definition here, stage 2b means the tumor has invades the parametrium but does not extend to the pelvic wall. Only the parametrium is as extended, not going to the side wall. But standard care, what will be the standard? Because it is a locally advanced stage cancer, stage 2b to 4b, 4a, sorry, cervical cancer is definitive. This is the standard care treatment, combined platinum based chemoradiotherapy, okay, followed by brachytherapy. So this is the standard treatment which she has to be received. So chemoradiation, you know. Question 5. A 30 years old lady presented at 8 week of gestation for booking scan. So she came for booking scan. On ultrasound, no gestational sac seen in the uterine cavity, and both adnexia are clear as well. So she came for the booking ultrasound at 8 week. Okay, so there is no gestational sac seen, not. So her beta SCG is 40 after 48 hours ago was 3,200. Okay, and now today it's 3,270. So after 48 hours in state 3020 to 3,270. So to only 70 is increased, which is the most appropriate management. So what is the most appropriate plan he wants to know. So first he said repeat SCG, ultrasound after 1 week, laparoscopy, then the fourth is the methotrexate. The correct answer is methotrexate. So why we are using the methotrexate? The question is here. See, she is 8 week, there is no intra-extrauterine pregnancy. So we'll say this is a pregnancy. Her this one, no gestational sac is seen on ultrasound. Okay, booking. And but adnexia also clear. Adnexia, both adnexia are clear, but her SCG level is increasing. Increase 48 hours, it become means substandard. So what we'll do, beta serum methotrexate. So why we'll use this one? He say, based on the clinical presentation, the patient this is called the pregnancy of unknown location, because it is there is no intra and extrauterine pregnancy. So with the plateauing now, the this is a plateau, because 3,200, then it becomes 3,270 after 48 hours. So this is the plateau with unknown pregnancy. So only 2% rise is there at the 8 week of gestation. So there is this, we call it there is a discriminatory zone between more than 1,500 to 2,000 with empty uterus. On TBS we have to this we call it as just this is abnormal pregnancy, such as the missed abortion or ectopic pregnancy, but abnormal SCG. With this abnormal SCG, this is we get it the plan we get it plateau here. So the management is well above the this our SCG level, because 1,500 to 2,000 this discriminate, but it is above 3,270. Okay, so this means what he wants to say, that this means it is abnormal. So what is the treatment most appropriate we have to do? And we have to understand here the patient is stable, clinically she is stable, is to treat for a ectopic pregnancy, while some they say further monitoring. So we have a two thought of schools. We have to observe or we have to treat. So here the problem is there, that still the patient is stable. So immediate action can be happen, immediate thing can be happen that she can have a to have a rupture, the ectopic pregnancy. When it will appear, it can be a rupture. So to prevent this rupture of ectopic pregnancy of unknown location, we can do the treatment with methotrexate. This will be the best option. Appropriate management to treat suspected ectopic pregnancy. If the patient is stable and SIG is not increased normally above, it is not increased. So the patient is if the patient she become unstable, then we have to go for the laparoscopic surgery would be indicated. But here the patient is stable, so we'll use the non-invasive procedure like methotrexate. Okay. Question number 6. A 32 weeks lady, 32-week pregnant lady with IUGR on ultrasound, AEDF, okay, absent and diastolic flow she has having on Doppler, and the baby weight, estimated fetal weight is 1.7 kg. So we have to understand this is IUGR. So what is the most appropriate option? The first one is that we will admit her steroids. We have to give twice weekly. We do the CTG and CTG on alternate days, and then we have to do the Doppler and cesarean at 34 week. Admit her. We will give her the steroids twice daily CTG, twice weekly twice weekly umbilical artery Doppler and section before 34 week. Here the thing is it's only the absent, okay? And the C is 2 weekly growth scan and admit for emergency delivery. So we have to understand here these are the options which we have in our hand. The most appropriate option is A. We have to admit her, give her the steroid twice weekly, do the CTG. Why we are doing the CTG? Because we have to check if the any abnormality in CTG is there, and alternate days ultrasound Doppler and cesarean at 34 week. Why we choose that A? Our choice is that we have to admit her and give the steroid because she is having an absent and diastolic flow at 32 week. It means indicates significant placental insufficiency, and she has a high risk. This is a high risk finding which we have it. So admission has to be necessary for intensive monitoring. The monitoring we already done now, so she has to receive the steroid and the daily CTG, twice daily CTG, and to monitor the fetal heart rate pattern for the sign of acute distress. So this is the problem we have to legal because 32-week baby is still preterm. That's the reason we will try to wait it. And in case of absent and diastolic flow, daily or twice daily monitoring is a standard to detect the certain deterioration. So that's why we are doing. We can do the daily CTG or we can do the twice a week. He say twice daily. Okay, 2 times a day. And alternative we are doing umbilical artery Doppler. So, and why we are doing the section at 34 week? The guideline they are recommending between 33 to 34 week of gestation. If the other means Dopplers are others surveillance are normal. Otherwise, we have to because we are monitoring her. So we have to do for the cesarean because still she is a IUGR baby and she will not tolerate the labor, stress of the labor. IUGR baby and the weight is less. It will not tolerate the stress of the labor. So that's why we will go for the cesarean section. I hope it is clear. So for the question number 7, she is a primary gravida at term, induced labor, ARM done at 2 centimeter and she is on epidural. Contraction, she is having a contraction 3 in 10 per minute, and on auscultation fetal heart rate at least at once dropped to 60 beat per minute, and does not recover to normal up to 30 seconds. 30 seconds it is not recovering after the contraction is subside. So PV done, she is fully dilated. Station head is +1, left occipital interior, mild capit, no molding, which is the most appropriate management plan. Forceps or vacuum, delivery by cesarean section. We have to examine her after 2 hours and oxytocin infusion. The baby is already in distress, so why will use the oxytocin? Already she is fully dilated, and then the problem is the fetal heart. So we cannot examine her after 2 hours. Deliver by cesarean. She has to be delivered by cesarean section, but the cesarean section need the timing. And here the head is only +1 station, and there is only mild capit, no molding. So the best option is forceps or vacuum. Why we will use the forceps or the vacuum? The doctor who is means very trained, whichever instrument he wants to use it according to the circumstances. So they can use it forceps or vacuum. So explanation I already told you. So question number 8. Patient with diachronic diamniotic tune, the first baby deliver vertex, the second baby vertex, head is high up. Okay, no contraction is there since the first baby deliver, and the CTG is normal. And please, we have to remember this question. This is a very repeated question in the exam. On and off they are giving this question again and again. Okay, so we have to know what is the option they given. Commence syntocinon infusion, ARM to be done, observation, cesarean section, vacuum, or the force, or the forceps. The answer will be A. Commence the syntocinon infusion. Why we do? If we look for the question, baby first delivered. The second head is high and there is no contraction. They give us the clue, no contraction. So what we have to do, we have to start the contraction, and now we are going to start the contraction because our CTG is normal. So we can start the syntocinon infusion. So this is the answer. Question number 9. She is a primary gravida, 36 week of gestation. She came with abdominal pain, right upper quadrant pain. Her BP is 140/90, proteinuria +2, glucose less than 2 millimoles, elevated glucose +2 glucose, and she has 2.2 millimoles elevated liver enzyme. What is your diagnosis? So he wants to know the diagnosis: AFLP and preeclampsia and the HAL syndrome. Here we have to use is acute fatty liver in pregnancy. Why we don't use preeclampsia and why don't we use the HAL syndrome? See, if they given us about the HAL syndrome, platelets they have to give it. So here the platelet they did not give us, they are low or whatever it is. So HAL syndrome is gone. Now we have the preeclampsia. Preeclampsia, the BP is okay, normal, we understand. It can be a preeclampsia. The BP is here, the 140/90, and acute fetal liver. So because she is having a pain in the right quadrant, so that's why we will go it. Acute fatty liver in pregnancy is the means our diagnosis. With 3 conditions, they given it means if we'll compare, he want to share. If you will like to elevated liver enzyme, right upper quadrant pain, and the high blood pressure, the severe hyperglycemia, she is also having a severe hyperglycemia, 2.2, glucose is 2.2. So this is the pathognomonic finding of the acute fatty liver of pregnancy from the other, because here the diagnostic value is hypoglycemia. In other they don't have it. In pregnancy and the HALP syndrome we don't find it the hypoglycemia, severe hypoglycemia. So the question number 10, we did not able to get the age. Whatever age the patient is, that she is nulliparous with recent candidiasis. Okay, candidiasis. What is the most appropriate management she is having? What they are asking in the answer will be starting phase and the maintenance phase. We have to understand there are 2 phases when there is an infection. Here they are telling us she is having a recurrent candidiasis. So means she has taken the treatment, now it is coming again and again. So what we phase we will use it. We will use it the maintenance phase we have to use this. Okay. So here what we will see it, what will be there. The question means option 1, Fluconazole 150 milligram daily for 1 month and weekly for 6 months. Fluconazole 150 milligram daily for 6 months. Okay, for 1 month or weekly for 6 months. Okay, for so 6 months, and this is daily for 1 month and daily for weekly for 3 months. The last option. Here we choose it option two or a B option. A daily for 6 months. This is the standard treatment which we standardly we are using it. Induction phase means the goal is to achieve clinical remission. Okay, this is we will use it 150 milligram daily in series of over first week, means first week we are using it, but the maintenance phase, because already she received the treatment, so we'll use the maintenance phase. Here we will use, which is we call is the suppressive regime we have to give her, and the suppressive regime is that 150 milligram she has to take once weekly for the period of 6 months. For the period of 6 months. Thank you so much for the timing for today. We done the we done our RCPI written exam recalls March 2026, and I am very thankful for everybody who has helped us to get uh, this recalls, and I hope it will help to all others. Thank you so much.